second, dear colleagues. First of all, I very appreciate the opportunity to participate in such significant webinar in Sviatoslav Fedorov memory. So thank you very much. And my presentation will be about features of early idiopathic epiretinal membrane surgery. So with idiopathic epiretinal membranes, contractile fibrocellular membranes that occur on the inner surface of the retina, causing tangential forces, leading to a deformation of the retinal architecture and significant visual impairment. Idiopathic ARM consists of different types of cells, including glial cells, hyocytes, retinal pigment epithelium cells, fibroblasts and myofibroblasts, and extracellular matrix. The importance in ERM development, as a different study showing, is that retinal Müller cells and other cells is in the presence of a certain profibrotic cytokines can transdifferentiate in a myofibroblast-like phenotype and start to produce alpha smooth muscle actin and induce tissue contraction that cause metamorphopsia, which is usually the leading and most disturbing symptom of the disease. Surgical removal of ARM and LM is usually performed using a 25-27 gauge vitrectomy systems. During surgery, both the IRM and ELM must be removed from the retina completely in order to release the traction on the macula. Surgery for IRM improves or stabilizes visual acuity, decrease metamorphopsia, and restore macular anatomy. Nevertheless, patients with a low preoperative visual acuity do not enjoy a complete recovery after membrane removal. Limited restoration of visual acuity in these patients can be due to chronic tractional syndrome, vascular leakage, and persistent cystoid macular edema. And the purpose is to investigate the functional, structural, and morphological outcomes of ARM surgical treatment in different proliferation phases. 60 eyes of 60 patients who underwent 25 gauge pars plana vitrectomy were evaluated in this study in 1, 3, 6, 12, and 24 months after surgery. All patients were divided into 3 groups in relation to visual acuity, and the presence of the present study evaluates flat-mounted ERM surgical specimens for evidence of presence of different type cells transdifferentiation, or retinal Müller cells, astrocytes, hyocytes expressing glial acid fibrillary protein, GFAP. This is a marker of cell activation. Also, vimentin, CD45, cell-expressing alpha SM actin, that is myofibroblast marker, and types of collagens. We want to demonstrate ARM-LM removal in different groups. All the membranes in first group were removed separately from the LM after dual blue staining with a HAPF 24-5 gauge forceps. And after a complete RM removal with a single piece, we performed macular axis LM peeling. And here we present the video from the second group. In the second group, all membranes were removed in a single block with ILM, and you can see it clearly because of quite strong adhesion to the retina and some diapedesis on the retinal surface. In the third group, we revealed most strong membrane adhesion to ALM. even a crest-like adhesion to the whole retina. Sometimes in the fovea, and they were also removed in unique block, as in group 2. Sometimes trying to minimize tractional forces on the macula, and we sometimes performed vitrectomy around the remodeling tissues and retinal crest. And we performed double staining to make sure to complete ILM removal. All surgically removed IRM of first group specimens were found to have positive immunostaining for glial fibrillary exit protein, GFAP, CD45 and V-maintained, indicating the presence of glial cells and hyalocytes. We observed alpha-SM actin also positive cells in 12 samples. They were transdifferentiated retinal Muller cells and astrocytes into myofibroblast-like phenotype. They start to produce a smooth muscle actin and induce tissue contraction. And in this case, symptomatic patients start to complain of decreased visual acuity and metamorphopsia. As you can see, ERM and DLM specimens in this group were removed separately. In the second group, we revealed progressive increasing myofibroblast-like cells that is responsible for the upregulation of type 2, 4, 6 collagen. Also CD45 positive hyalocytes and reduction of GFAP positive cells. We concluded that the alpha-SM actin expressing transdifferentiated Muller cells and other cells, which represents myofibroblast-like cells and responsible for the membrane contraction. In the third group, membranes were representative of extracellular matrix, component combinations, collagens 4 and 6, lethal activated hyalocytes, and alpha-SM actin positive cells. This membrane had strong adhesion to LM and were removed in unique block during vitrectomy, and we didn't observe any Muller cell or astrocytes in this type of membranes. In the current study, we showed that progression of IRM can be considered as a proliferative fibrotic process with collagen deposition and further membrane contraction. Increased expression of the transforming growth factors induces differentiations of different cells into myofibroblast-like, granting ARM their contractile properties. In the ARM represents many types of collagens also. Improvement of postoperative best-corrected visual acuity, as well as statistically significant central foveal thickness reduction was observed in all groups, maximum after 1 year of observation. Postoperative BCVA was significantly better in patients with good preoperative visual acuity. In comparison between 3 groups, it was found that there was a significant improvement on BCVA and central foveal thickness in the first group. These patients have very little macular damage, resulting in good recovery of the macular function. The postoperative ISOS alterations and macular edema was very significantly higher in the second and third groups. On this basis, it could be concluded that the membrane thickening and contraction due to cellular transformation leads to distortion in the external and internal retinal layers. That's why an early intervention prior to the induction of permanent damage seems more rational for better visual outcomes. Thank you very much.